everyone. It looks like we have a growing audience, so we can get started. My name is Jimmy Bowen. For those of you I haven't met, I'm one of the pediatric chief residents, and I have the pleasure this morning of introducing Dr. Jones as our Grand Rounds speaker. Dr. Jones is an assistant professor of pediatrics in the Division of Hospital Medicine at Cincinnati from the University of Pittsburgh School of Medicine, master's in medical education from the University of Cincinnati College of Medicine, and completed her pediatric training at the University of North Carolina. She's a career focused in medical education with an emphasis on simulation and continuing medical education. She serves as the medical director for continuing medical education at the Medical Center and director of simulation education for the suburban campus. She recently completed her term as co-chair of the National Pediatric Hospital Medicine Annual Meeting and is a course director for the Cincinnati Pediatric Hospital Medicine Board Review course. In her role as Diversity, Equity, and Inclusion Liaison, she works with institutional leaders to operationalize the Faculty Diversity and Inclusion Plan. She is also a founding member of Advanced PHM, a national organization dedicated to join me in welcoming Dr. Jones this morning.
Thank you, Dr. Bowen, for that very kind introduction. Just want to make sure you all can hear me okay, because you were breaking up for me during your presentation.
Yes.
Yes, okay.
You're not breaking up.
Okay, well, let me go ahead and share my screen and share my slides. This always feels like it takes me longer than it should. Okay, here we go. All right, can you see that okay still?
Yes.
All right. Well, it is truly an honor and pleasure to be with you all today. Sadly, it's virtually. I would have loved to come in person and see some old faces and friends and meet some new ones, and even see the not so new hospital anymore. It opened shortly after I left. So hopefully one day we'll be able to be together again in person, but still a pleasure. Thank you, Dr. Ben Miller, for the invitation to present today. So you see the title of my talk here. I'm hoping to continue the conversation that you all began with Dr. Jessie Allen a few months ago on the topic of gender equity in pediatrics. She did an excellent presentation because I know her well. I'm sure she did an excellent presentation, and I saw some of the things that she had talked about. And she really, I think, laid out a lot of the issues for pediatricians. Today, my focus will be honing in on leadership and promotion, specifically in academic medicine, of course, with a special focus in our field, pediatrics. I have nothing to disclose. And our objectives for today are to describe the persistent gender disparities that we see in pediatric academic leadership and advancement. We'll discuss the impact of gender segregation on our field, and I hope you'll be able to identify at least one structural solution to help to eliminate gender inequities in academic medicine. So as a medical educator, I'd like to borrow from the 12-tip series in The Medical Teacher to frame our discussion. Just silencing my phone, give me 1 second here. So today we're going to focus on 6 tips for a more equitable future in academic medicine. So for those who attended Dr. Allen's presentation, to sort of get a sense of where we all are, I would love to get some input from you. I understand that she asked you to commit to an action at the end of the presentation, what you would like to do to work on this issue. And I wanted to hear what folks are working on and potentially how that's going. So I believe there should be a poll question coming up. If you could put in there just what your action was that you committed to, hopefully at the end during Q&A, we'll have a chance to discuss maybe how that's going. So I'll give you all a minute to see, and hopefully, Colleen, that's working. We'll use the chat, okay. Oh, here, I see something. Okay, sponsor women colleagues. That is definitely an important one. I'm not seeing any others, so hopefully we'll give you some more ideas today on how we can act. Okay. All right, so jumping right into tip number one, I think you can close out the poll, Colleen, if it's still active. Okay. Tip number one is to recognize disparities in academic leadership and advancement. I'm not going to go in too much detail about this, as I will refer you to Dr. Allen's presentation. And I will preface it by saying that, like many complex problems, the underlying reasons for these disparities are, of course, multifactorial and quite complex. They can include things like implicit bias, societal expectations and norms, structural factors, and even work culture. So this graph is going to highlight the gap in the disparities in publications that we see. And this is from a study that looked at the 3 highest impact pediatric journals, Journal of Peds, and JAMA Peds. The main takeaway here is that there's been a slight increase over the 16 years of the study. Publications among women have gone up somewhat, so over 2001 to 2016. However, you still see there's a gap. So the blue line here is the percent of junior faculty that are women. And the red line is the percent that are first authors. And there's still a bit of a gap there in the productivity of the junior faculty. The senior faculty line is much more overlapping, but you can see there's still, I think, a decent amount of underrepresentation of women faculty here, as they're only around 40% of the publications. The similar trend here in editorial leadership. If you look at the green line, again, an upward trajectory, which is great to see, but still an underrepresentation with around 40% of editorial board members being women. And this is for journal editors. Looking at institutional leadership, here we see that the representation of women in leadership positions across different types of healthcare organizations, from the HHS to different health systems to health insurance groups. I want to highlight the C-suite levels and proportion of women, which we see is very low. Around 15% of C-suite CEOs CEOs of healthcare organizations are women. In this study, they looked at members of the boards of directors and found, those folks are, one of their responsibilities is hiring a CEO, and they found that boards of directors that had more gender diversity actually tended to have women as CEOs, or had a higher likelihood of having women as CEOs. This reflects some of the findings that search committees, when there are more women on the search committees, also tend to interview and hire more women. When we look at our field specifically, pediatrics, we're still around a quarter of pediatric chairs that are women. So definitely some room there for improvement. This mirrors the numbers of full professors that we have in our field as well. And then similarly, looking at president equivalents of our societies, looking at the members of the Federation of Organization of Pediatric apologies, I thought I had silenced it. Pediatric organizations, so the AAP, the ABP, APA, those sorts of organizations, the president equivalents, there's still less than half that are women. And then looking at invited lectures and speakers, again, we see a gap here in the percent of women pediatricians. Looking at this aggregate number, the black bar is telling us the percent of women, according to AAMC, there were percent of pediatricians that were women in 2017. And here you can see the blue bar, which is delineating the proportion of men that were speakers, and the red bar is women. A big gap you can visually see between the proportion of women pediatricians and the invited speakers. So a lot of these prior gaps inexorably lead to a gap in academic promotion, as all of those are sort of components of the currencies and the evidence of academic scholarship and excellence. So despite accounting for over half of full-time pediatric faculty members, we can still see that women hold only slightly more than 40% of associate and full professorships. I'm going to blow this graph up a little bit for you. This is showing the percentage of women at each level, at each rank, instructor to full professor. And you can see the main thing I want to highlight here is that the only rank at which women are in the majority, despite being in the majority in the field, is at the instructor level. And obviously going up, you see a drop off. Said a different way, out of all full-time male full-time pediatric faculty, 27% are full professors, and only 11% of female faculty members are the same. So this is important because much of the pay disparities that we see in academic medical centers is actually driven by academic rank differences. And so facilitating equitable promotion and moving those women from instructor and up the chain will actually help to eliminate some of those differences. All right, so we're going to move outside the workplace. And again, here we can see gender differences that I think here really reflect larger societal norms. So here we're looking at, on the y-axis, the percentage of responsibility, and on the x-axis, you have different household tasks from laundry, shopping, cooking, cleaning, and then the bar for women and the bar for men. So women here, they looked at 16 different household responsibilities, and women were more likely than men to report having primary responsibility on 13 of those 16. And those tended to include things like cleaning and cooking and care of the children. So why do we care about the division of household labor? So the research shows that work-life conflicts, sort of that push and pull between work and personal tasks, has been associated with higher rates of burnout and sort of personal distress. Gender is a key factor that's associated with that work-life balance satisfaction. And something else to consider is that dual professional relationships are known to be particularly prone to work-home conflicts, which is a key contributing factor, again, to burnout, depression, and workplace dissatisfaction. So in this study, of the women who were partnered, 80% of them had a partner who worked full-time, whereas only 40% of the men had a partner who worked full-time. So you can see how these factors can contribute to women potentially being less willing to take on leadership roles at work and even being less productive. So finally, much of what we see in the gap for women in the workplace across many fields, and certainly in academic medicine, has been tied to having children. It's sometimes called a motherhood penalty. This is a graph showing one author's publication record visualized over time with academic, her year since her first academic appointment on the x-axis and the number of publications on the y-axis. She has annotated the births of her children and her different academic appointments along the way. And the main thing here to note is that there's sort of a flattened curve early on as she's clustering in having babies, and a longer lag time between promotion to associate professor as there is to professor when her kids are older. So the societal norms and are unlikely to change very quickly. Hopefully they do continue to evolve, but it's a very slow process. So I expect women will continue to shoulder the burden of caregiving and household duties. Helping women balance and find balance so that we can retain women in academic medicine will be crucial to getting them to go up that ladder, even if they take a bit longer to get there as they're balancing both sides. Okay, so whirlwind tour through all of that. Hopefully that was all a review. Tip number 2 is to abolish the citizenship tax. So we've talked about some of the major areas of gender disparities that we see in pediatric academic medicine. I purposefully left off the pay gap. We'll talk a little bit about that later. I know that you all delved into that a bit last time. The next tip is really getting at one of the underlying reasons for some of the gaps in achievement that we see. So what is citizenship? I'm going to define that. Define this as any uncompensated work. It's work-related duties. It requires time. It's often performed at work, but can be done after hours. This is usually things that we volunteer for. They're roles that contribute to the organization's performance and are very important to maybe the efficiency or to achieving the missions of our institutions, but are less likely to contribute to career advancement. So examples would be in our field, things like helping with recruitment, doing interviews and interview dinners, back when we used to do interview dinners, advising, mentoring, committee assignments, particularly those that you're asked to do because of your gender or race, taking notes during a meeting, posing for pictures, working on DEI efforts with unprotected time. I want you to just take a few moments to think about, with all these tasks, who in your group, in your division, in your department usually does these things. So why does it matter? Certainly, being a good citizen and a good engaged member of your department or your division can be a great thing. And there is a positive relationship between organizational citizenship behaviors for both the individual and the organization. You're helping the organization meet its missions. A positive and engaged workforce is more productive and less likely to turn over, and that can be good all around. But two cautions that I want to highlight are the effect of citizenship fatigue. So this can occur when employees are demonstrating high levels of citizenship behaviors, but the organization is not necessarily either rewarding or acknowledging that citizenship, and that can lead to dissatisfaction. That dissatisfaction can even lead to burnout, and this is important because there's a disproportionate burden on women for citizenship tasks. I'll talk about the specific impacts in just a bit. I'm just going to take a look at the chat. There's a couple things. Okay, yes. So not all service is created equal. A key point I want to highlight is also that there are clear differences in disparities by gender, whether that service is external or internal. So gender disparities in service appear to be more pronounced when we look at internal than external service. This is similar to what's been found in the corporate world, where women were less likely to be given sort of the glamorous work that could garner outside recognition, the opportunity to stretch their skills, and instead they were given more, for lack of a better term, office housework. And that's things that are more administrative in nature, things that involve maybe emotional labor. In the academic context, we can think of external service as maybe service to our professional societies, specialty societies, conferences, and that can produce increased visibility, maybe lead to collaborations, grants, and even job offers. So thinking about not just the quantity of service, but also the balance of internal versus external can be helpful, I think, when we're mentoring women. So even though women appear to have no greater preference for service than men, they are more likely to take on these extra assignments. These taxes take time, so they diminish the time for things that are truly valued in academics that I highlighted in tip number 1, which can place them at a disadvantage for promotion and advancement. Talked about citizenship fatigue already and how that can also lead to burnout and dissatisfaction with our work. And leadership opportunities, I think, can go both ways. Certainly with certain service assignments, it might actually put you in a better position to take on a leadership opportunity. But as I've also mentioned, it can potentially hinder that. So promotion and tenure committees can place higher value on tasks like teaching and mentoring, which women tend to volunteer more for. which are also really central to our academic mission. All right, tip number 3 is to acknowledge the varied experiences of faculty that are underrepresented in medicine. So we know the experience for all women is not the same. And while we're talking about equity and advancement and promotion today, really focusing on women, many of the same issues exist for men and women that are underrepresented in medicine, particularly around this idea of the citizenship tax. So it's often called a minority tax because of minorities who are taking on these extra duties, but you can also look at it as a majority subsidy. And that means that work that minority faculty may be doing, especially in the DEI space, presumably are beneficial to all, but because it's taking time, they're taking the time to do it, and it's disproportionately being performed by them, it's actually in effect subsidizing the time of the majority faculty. So women of color in particular may be asked more frequently to serve in specific types of committees, as we're all looking forward to do more in the space of diversity and equity and inclusion. But oftentimes this work is not counted in the same way as other contributions. And so one thing to think about is just really valuing the efforts of diversity, valuing the efforts of faculty members towards diversity as much as we do other things. And then here's a graph highlighting, I think, one of the more core issues for underrepresented faculty, which is just the low numbers. I'm going to blow this up as well. So this is a graph showing along the x-axis is years from 2000 to 2016, and then on the y-axis, the percentage of women faculties broken down by race and ethnicity, the purple line being white women, and the green line is Asian women, and then the bracketed lines at the bottom are all the underrepresented faculty. And so this is actually 5 lines put together that totals 13%. So just really, really small numbers. And while this number is very small, I think the sort of more discouraging fact about this graph is how flat the line is. So if you look from 2000 to 2016, it really hasn't changed very much, maybe gone from 12 to 13%. So that's kind of disheartening to see. So the numbers of underrepresented faculty is very small. And for that reason, I think a lot of times when we're looking at gender equity efforts, and probably not disaggregated by race and ethnicity, but it really needs to be in order to see what the issue is and to track it moving forward. Is to become a critical actor and a critical ally. So some argue that the persistent disparity that we see in leadership in medicine is simply a matter of time. We have lots of folks that are junior that are coming up, lots of medical students and junior faculty and instructor level, as I showed. And given enough time, all those young physicians will eventually rise into leadership as we develop a critical mass in the field. Well, this hasn't happened. Critical mass theory actually posits that once a proportion of faculty reach, say 30 to 35% is the number, their impact on the culture would be evident, and you would see that in the leadership, in the change in leadership. So women faculty have been greater than 30% for quite some time, and we haven't seen that drastic shift in the percent of women who are in the leadership. So the pipeline is not the problem. Instead, so there continue to be obstacles for women, and this study by Hellitzer and colleagues was a qualitative study where they conducted interviews with members of or participants in career development programs like ELAM, and conducted focus groups with institutional leaders, and really talked about a lot of the issues that women are facing and barriers to advancement for women. They concluded that the the promise of this critical mass sort of magically being a turning point for women should really be abandoned, and instead propose that we need to really rise up critical actor leaders, both women and men. And these are folks who are going to be individually and collectively able to have the power to move the culture in academic medicine to one that's more equitable. Another point in favor of sort of this critical actor idea versus a critical mass is the evidence that when we have women leaders, their achievements are actually more influential in helping the equity for women than a critical mass of individual women throughout an organization. So this diagram is depicting the action of critical actors on the various spheres that affect women faculty being at the center here, and this being the extra institutional spheres, intra-institutional, and the individual spheres. And so just sort of showing how critical actors working extra institutionally can affect the change in culture in the institution, and that can lead to a more equitable environment for women. So keeping with the critical actor theme, I wanted to share an example from the pediatric hospital medicine community. I've had the pleasure of working on the steering committee of Advanced PHM, which was started a few years ago with the goal of basically moving from talk to action. And the organization is work through education and research and a fellowship that's in development. There are also many committees and task forces in our various professional organizations that are committing to do this work, where critical actors can also make an impact. So speaking about allies and allyship just in a little bit more depth, I like this definition of allies from the American Psychological Association, because I think it's really robust and a little bit challenging. But they define allies as people who recognize the unearned privilege they receive from society's patterns of injustice and take responsibility for changing these patterns. I like the start of this definition because most of us, even if we are minorities in some aspect of our identities, have experience being in the majority in others and can work to take on this responsibility for inequities for others. So they go on to say that being an ally is more than being sympathetic and feeling bad for those who experience discrimination. An ally is willing to act with and for others in pursuit of ending oppression and creating equality. Real allies are willing to step out of their comfort zones. Those who decide to undertake the ally role must recognize and understand the power and privileges that one receives, accepts, and experiences, and they use that position to act for justice. So what does allyship look like? I would highly recommend this article for those who are interested in, what more can I do? Dr. Spector and colleagues delineate in a really nice table sort of various activities and actions that they propose, in including timelines that individuals and organizations can do to move forward in our field. So it really depends on your sphere of influence, whether that be, with the NIH or at your institution or even at the individual level, there is an action for you. So it's a really great article. So a few suggestions for what we can do as allies that I wanted to just propose to you all. So include women on committees. I mentioned in the CEO example that there is evidence that when you have more women on search committees, that you tend to hire and interview and hire more women. So including women on search committees, promotion and tenure committees can be really important for that work. Also ensuring that any open positions are publicized widely and not just sent to a select group of folks that sort of reinforces existing networks. And then sponsor women for these roles. I'm glad that Dr. Choi mentioned that sponsoring was one of the things that she had committed to do. We know that women often do not think of themselves for roles, and even when they're asked, they can decline them. So having a powerful sponsor who believes in her can make all the difference. Providing grants for conference attendance can also be really helpful when we go back to attending conferences. Oftentimes women are inhibited by childcare and needing to bring children with them and having childcare issues. Providing one-on-one coaching to help women who are navigating their careers and career trajectories as they prepare for the next steps can also be helpful. All right, tip number 5 is to mitigate the impact of the pandemic. So we know from various reports, including one from the National Academies of Sciences, Engineering, and Medicine from 2021, they had a report on the impact of COVID-19 on women in the fields, and it has had a detrimental effect across many different areas. So 2 areas in particular that have been aggravated, or 2 that I've already sort of touched on: academic productivity and that blurring of work-life boundaries and work-life balance. So I had the opportunity to reflect on the potential damaging effects of the pandemic early last year with some of my colleagues from Advance, and we had several suggestions at that time to hopefully head off the issues that we saw arising. I want to expand a little bit on the issue of academic productivity and administrative contribution. So at the time, we recommended to institutions to provide a mechanism for decreased academic productivity that was, sort of clearly going to be on the rise. Here is a COVID matrix that Dr. Aurora and colleagues devised, which is something we actually use at our institution. We've modified it for use during our yearly faculty evaluations. This matrix was created to better enable academic professionals to document their contributions during the pandemic and also any disruptions that may have occurred. Documenting these experiences can just provide a more holistic view of what a faculty member is contributing and even how they're being affected by the pandemic for promotion and tenure committees to look at sort of fuller picture of their CVs. So this is an example of one individual, how they were sort of adjusting for COVID time across various categories, specific activities that they may have taken on in the short description. So other strategies to consider when we're looking at the disruption of academic productivity during this time is to sponsor women for specific COVID-19 funding, with COVID-19 research funding, which may be more plentiful at this time. Recognizing and developing promotion structures that recognize not just COVID-19 research, but also clinical care, administration, and teaching, which have been just so critical during this time. And then considering extending promotion deadlines for faculty to account for those disruptions. And it can be helpful to sort of normalize them so that it's for all faculty instead of having sort of individuals, and to sort of destigmatize any disruptions for folks. And then another recommendation we had was to recognize and reward efforts for clinical and even administrative contribution. Again, recognizing that women tend to be overrepresented here. So when we think about compensation, something that can be helpful is standardizing how professional effort is calculated amongst the 3 mission areas. So, research, clinical care, and education, and identifying appropriate benchmarks that then apply across departments and divisions. I'm a big fan of salary audits, and so conducting those regularly. Unfortunately, even after a salary audit and correction, if you come back a few years later, you often find that things have gotten out of whack again. And so those need to be conducted periodically. And when doing so, considering not just the base pay, but also the incentive pays and leadership stipends that may be a part of compensation, with an eye to balancing those out. We know that women in medicine, as I've described, have well-documented disparities in leadership and leadership opportunities. So that may be limiting some of their earning potential. And then finally, because women are so disproportionately assigned to uncompensated tasks, service-related tasks, trying to capture some of that non-clinical effort in salary studies, I think, can also be helpful as it relates to the non-clinical stuff. All right, moving on to tip number 6, is to work to reverse the effects of gender segregation. So what is gender segregation? Those of you who are Harry Potter fans may recognize this hat as the sorting hat, which was used to sort wizards into different houses based on their individual strengths. So while we don't have a sorting hat for medical students, we do see evidence of sorting that is by gender across the different specialties. Students, medical students at this point are near 50-50 for men and women. When we look at individual specialties, that same 50-50 breakdown is not seen everywhere. And we certainly have fields that are much more heavily feminized and masculinized. So why are medical students sorting by gender? I'm sure there are individual preferences, but we know that systemic factors like overt harassment, structural sexism, and implicit bias are also playing a role in career choice. I think it can also be a little bit of a self-fulfilling vicious cycle where fields that have few women have less role models for medical students coming up to see themselves in, and fields that have more women, whereas readily apparent, sort of then can recruit medical students into the field. So there's a phenomenon known as the tipping point, where once a significant number of women enter a previously male-dominated occupation, and this has been shown across many different occupations outside of medicine, that occupation experiences a rapid swing to female predominance. And I think this is what's happened in pediatrics. We are certainly a female-dominated field. Surgery and neurosurgery are very male-dominated. So what is the impact on having a feminized field? One is actually pay. So that gender pay gap that we see for individuals and for women at large then sort of bleeds over into the entire field and affects men and women. When a field is feminized, both men and women are also less likely to want to enter the field. And there can be a loss of prestige that may be tied to the compensation decline or the earnings decline when there's an influx of women in occupation as well. And this, of course, is rooted in, I think, gender stereotypes and the social hierarchy that we still have, where we confer higher status on men than women. So a bit more about salary. The lower salary of feminized occupations is certainly a contributor to the pay gap. We know that women are overrepresented in low-paid occupations and men are overrepresented in the highly paid occupations. And there's evidence that this is because of a true devaluing of women's work, because we see that in professions where there's more than 75% of women, so female-dominated professions, they earn less than mixed 25 to 75%, and they earn less than male-dominated occupations, which is more than 75% male. Looking at our medical specialties, this is a study that looked at the salary differences in medical specialties with sex distribution. In this scatter plot, you can see a clear linear association between the percentage of women in the field and the median salary along the y-axis there. And for every 10% increase in the percentage of women present here on the x-axis, men's salary actually decreased by $7,500. As bad as that is, it's actually worse for women. So it's a stronger association for women in that there was a $15,000 decrease in women's salary for every 10% increase in women. So we know this association is not causation. So, again, this is a very complex issue, the pay issue, and some of this is partially due to the way that the US medical system reimburses, and we know that it values procedural specialties more so than other services. And it's certainly quite possible that women are attracted to and even encouraged to enter specialties that involved more of those traditional feminine caregiving aspects, which happen to be reimbursed lower, like pediatrics. But it is imperative, I think, for our field that we continue to recruit a diverse workforce of both men and women medical students and encourage people to enter our field to minimize some of these issues. Okay, so just to recap the 6 tips, and I look forward to engaging with you all in discussion. First is to recognize where the issues lie, and hopefully that was a review for most of you, and the issues that we continue to see over and over in academic medicine, to abolish that citizenship tax that affects women and particularly minority physicians more so, to acknowledge the varied experiences of underrepresented faculty, and to really accelerate efforts at recruiting more faculty into our field. And I think this starts really early on, quite honestly, probably in childhood, to get more underrepresented folks into medicine. To mitigate the impact of the pandemic, we talked about specifically on academic productivity and compensation, to become a critical actor and ally. And there are many different ways that we can, I think, partner in this work, and then to work to reverse the effects of gender segregation. All right, these are some of my references, and I look forward to hearing any questions that you have. Let me take a look at the chat and see. Some things have come up. A comment from Anna Radovic. In some other countries, pediatrics is one of the most respected and highly regarded fields due to its complexity and importance of children. Yeah, that is true. Yeah, I think my understanding is in the UK system, pediatrics is sort of a specialty. General practitioners see everyone, and then pediatrics is sort of that next level up. And so, yeah, there's definitely different ways that it could be structured.
Dr. Jones, I can relay a question from Dr. Mateo in our adolescent department. She said, as pediatrics today has significant numbers of women, but this was not true in the past, for example, in the 80s when she was a resident. Do you know if the average salary for a pediatrician has gone down proportionally as the number of women has increased?
It has. It has. And so that's, and I don't have the graph up here, but that is one of the evidences that it's actually the devaluing of women's work, because as the field has become more feminized, proportionally the salary has gone down. And that's been shown for not just pediatrics, but for other fields as well.
And Dr. Choi is wondering if you know of any possible solutions for the childbirth tax that women pay in terms of academic promotion.
Yeah, I know it's a tough one, and I've reflected on that myself too. And speaking of the childbirth tax, I'm actually just coming off of maternity leave. This is my first week back, so I totally appreciate what that means for women. I think part of it, and I don't know if this is a cop out or not, but I do think for me it's sort of resetting expectations, because we know that women are physically the only ones that can give birth to children. That's not going to change. And there's always going to be some effect of even just physically what happens with women. However, I think societally, we know that the US is not it's not the most supportive of women having children, and even supporting that time after birth. So we do see evidence from other countries, and I think that childbirth tax can be less because there's more support from the governmental to institutional levels for women after having children. In the US, I don't think we are culturally there. So I don't have any answers for that, the culture issue. But what I do think is helpful is, again, just recalibrating that this career is not a sprint, it is a marathon. And we're going to have different chapters and different pages. And, whereas you might be a bit slower in that phase, a bit flatter on that curve where you're having babies and raising small children, that we're sort of looking to the beyond, and we know that we're going to try to ramp up. I think what happens often in academic medicine is that we don't retain women after they had children, and maybe we're not supportive enough to help them get through that slow period or that hump. But if we keep women in, we can catch up, we can ramp back up, and we can be very productive as our kids get older, and we're able to focus more on some of the academic products.
An additional question from Dr. Zara in our general academic peds department. She was saying, in non-medical academic positions, the 3 areas for promotion are teaching, research, service, but service does not seem to factor into medical academic promotion. Would adding a 4th category for clinical, teaching, research, service be helpful for those who are given more non-compensated tasks?
Yeah, I think that's some of the stuff that we need to address absolutely as institutions. Is this work important for the academic mission, or is it not? And if it is important, then we need to evaluate accordingly. And I do think that there is work for promotions intended. A new DEI faculty plan that we're really rolling out, and I think for the first time, it has some teeth to it and has some resources behind it. And one of the things that we're looking at is our promotions and tenure process, and really calling out specifically things like DEI as part of the promotion guidelines and part of how you can get promoted. So yes, short answer, yes, I do think that incorporating and including more explicitly recognition of some of those less valued tasks and valuing them higher, because they are still important, valuing them higher can be helpful for women. I mean, the other thing is, obviously, our male colleagues can volunteer for more of these things too. So, I think it goes both ways.
Dr. Radovic, just wanted to say thank you for this talk. She's wondering what your thoughts are for the structure of academic medicine with the pandemic and opportunities for telemedicine and work from home. She said more fulfillment seeing her children than more often while working from home, which helps with job satisfaction. Do you feel like there are any recommendations for academic institutions to continue some of the policy changes that COVID started and to implement their own policy changes about paternity leave, et cetera, despite no federal changes?
I do, and I think we need to look to other industries here. And I know academic medicine and medicine in general is not usually on the forefront of, rapid, progressive changes like this. But when I look at sort of the tech industry, which is an industry that, needs to stay current with hiring and being competitive with keeping and retaining folks that they've hired for a very high skilled workforce, I think they are doing a better job in this area. And I think it's been shown for many industries. I don't know about academic medicine specifically, but a lot of the changes that the pandemic has wrought and has brought institutions and companies are needing to hold on to. So one of them is flexible work. And to the extent that academic institutions, I think, can continue to offer that, it will be helpful in retaining faculty for whom it has been helpful. And I think it's really more about offering options for people. So there are going to be some folks who want to get back in person and don't want to have the time at home, and find that blurring of the work-life spheres actually distressing. But for others like you who like it and who find it to be helpful, offering that. So flexibility is definitely what I've been seeing sort of in the rest of the corporate world, and I think can be helpful in academic medicine as well. Personally speaking, for me, that's one of the things I value most about being an academic physician, is the flexibility that I have. And so absolutely, I can appreciate how that might be helpful, as we're giving even more options to be flexible, to do flexible work.
Fantastic. Thank you, Dr. Jones. I think the questions are starting to slow down, so it may be a great time to give people a few minutes to switch over to the meet and greet Zoom link to get to know you a little bit more.
Okay. Thank you all so much. It's been a pleasure.